Thank you. I am not the next speaker. My name is Bill McFarland. I am on the board of directors of CurePSP, and I have the pleasure of introducing Dr. Jim Bauer. Jim Bauer is with the Mayo Clinic here, head of the neurology department, if I understand that correctly. Movement disorder. Wonderful doctor. You probably don't remember me, but I believe you confirmed the PSP diagnosis for my wife in 2006. Okay. How about that? That's good. Dr. Bauer.
Morning, everybody. I am very suspicious that a lot of you, if not all of you, have been through a diagnostic odyssey, trying to figure out what is wrong with me. And it's taken you from doctor to doctor to doctor. So in my talk today, what I'm going to try to do is give you the doctor's perspective. Why is this so hard for us? Why can't we just tell you what's wrong with you? Just for a disclosure, I do have some research funding from AbbVie. All right, let's start with a case. This is what we usually do in medicine. We're going to talk about Mr. T. And Mr. T is a 66-year-old man. He's married. He's a retired high school principal, and he has 2 adult children. In 2014, his family just started noticing he was less engaged in conversation. That wasn't his baseline personality. And he wouldn't smile as much. So they took him to their family doctor, and he said, "You've got depression. Take some Zoloft," which is sertraline. But he didn't really get much better. And so they went on. In 2015, he and his wife were taking their daily walk with their dog, and she just started noticing that he had trouble keeping up with her. And by middle of 2015, he started noticing that he was buttoning his collar buttons or his sleeve buttons, that he was having a lot of trouble, and his wife was having to step in and help him. So they went to their doctor, and that doctor recognized, she said, "You need to see a neurologist. I'm not sure what's wrong with you." Well, it took several months to get in to see neurology. So now it's December of 2015, and this neurologist recognizes, okay, you've got Parkinson's disease, and that's what's explaining everything. And they're finally upset about the diagnosis, but at least relieved they know something. And so they take Sinemet, which is carbidopa-levodopa. And this neurologist says, push up the dose, and they get up to 2 pills 3 times a day. And he's like, yeah, I think maybe I can button a little bit better. Things progress. It's now May of 2017. He's getting a lot worse, Mr. T. His speech is becoming more difficult to understand. He falls in the living room, hits the coffee table, needs some stitches. Calls the neurologist. Okay, bump up your levodopa. Keep going higher. Go up to 3 pills 3 times a day. But he's just not getting any better. Now it's September. He's falling once a week. Now it's Christmas again. Takes a long time to get an appointment. He finally gets back to the neurologist to see the neurologist. And the neurologist looks at him and says, maybe you don't have Parkinson's disease. But I don't know what this is. You need to go to Mayo or the University of whatever. Takes a long time to get an appointment at the University of whatever. Takes 4 months. They finally go in April. They're waiting for the diagnosis. They'll finally find out what's wrong with them. Could be anything. That's what they hear. Okay, what's the problem? Why can't we just tell these patients what's wrong with them? If we were dermatologists, if we were oncologists, if we were pulmonologists, we would take a piece of the tissue, call it a biopsy, send it to the pathologist here. She's going to look under the microscope, and she's going to tell us what our disease is. But we're neurologists, and this is what we have to biopsy. And these are very sensitive parts of the brain. We do brain biopsies for tumors and things like that. But for these diseases, you're going down to an extremely sensitive part of the brain that could cause death. You don't do that. So as neurologists, we have to make diagnoses the old-fashioned way. Okay? We have to talk to the patient, listen to their symptoms, examine them, and make a decision. And we use something called diagnostic criteria. That's actually what the pathologists do in the lab too. When they make a diagnosis of a certain type of cancer, there's criteria. How does the cell look? When you put a certain stain on the slide, does it turn purple? Does it turn red? Where does it turn purple? Those are criteria. Then they say this is cancer X. Well, we use the same thing, but we don't use slides. We use symptoms and examination signs. And we have a checklist, a criteria of how to make a diagnosis in a patient that we can't get a biopsy. So first, let's talk about the criteria for Parkinsonism. And you've probably heard that term a lot, Parkinsonism. Parkinsonism is a syndrome, okay? And there's usually two, or at least two, of four cardinal features. These patients often present with a certain tremor, and the tremor is a very common movement disorder, but these kind of tremors occur with the limb at rest. So for instance, if the arm is at rest in their lap and it's shaking, that's a rest tremor, as opposed to a tremor when trying to drink, which is a kinetic tremor or action tremor. They have slow movement, bradykinesia. Things are slowed. Their tone is rigid. That's something we examine for more than patients complain about, but when we examine a patient, we're testing the tone of their limbs or their head and neck, and it's rigid. And they have impaired postural reflexes. When we're walking down the street and somebody bumps us, we correct ourselves. When we turn, the centripetal force doesn't force us to the ground. We're able to correct ourselves. That's a reflex. It's a postural reflex. And these reflexes start to get lost in Parkinsonism, and they fall. So if you see a patient and they have two of these four cardinal features, then you can say you have Parkinsonism. These are how patients present. This is what they're aware of. They'll have the symptoms of a tremor. The spouse, family will know that their facial expression looks masked. Maybe their speech is soft, hard to understand. They might have some drooling. A lot of dexterity difficulties, troubles buttoning buttons, putting on earrings, tying shoes. Their handwriting becomes smaller and illegible. They have difficulty turning in bed, what we constantly shifting in bed. They'll have difficulty with that. They'll have difficulty getting out of the car. I just had a patient this week. He told me I had to sell a Cadillac, only 24,000 miles on it, because I couldn't get out of the damn thing. Slow shuffling gait and falls, unexplained falls. We're not talking about falls on the Minnesota ice. These are unexplained falls. So once again, if you've got two of these features, the patient has Parkinsonism. And as most of the public see it, Parkinsonism means Parkinson's disease. They don't understand that it's not one of the same. But I don't think I need to tell this audience that not all Parkinsonism is Parkinson's disease. There's also something called PSP. PSP usually presents with Parkinsonism, but the big top three differentiation between PD, Parkinson's disease, and PSP are these top three things. Early falls. Patients with Parkinson's disease do fall, but usually they fall after having the disease for 8 years, 9 years, 10 years. Patients with PSP present usually with the doctor complaining of already falling, maybe within the first year or two or three. You already heard about the supranuclear downgaze palsy. Basically, that's inability, or difficulty at least, to move the eyes. And it usually starts with vertical movements before horizontal movements. And it usually starts with looking down rather than up. They've already tried levodopa usually by the time they get to us, and they've had a minimal, maybe a modest, more likely not much of a response. Whereas Parkinson's disease patients usually come back, you've given me my life back. And then they have other features. Their rigidity is more midline rather than their arms and legs. They sit into a chair like they plop back into a chair instead of lowering themselves appropriately. Their gait, we talk about a lurching gait or a Frankenstein type gait, kind of wide-based and lurching down the hallway. Parkinson's disease patients have a masked face, but these people are called having a reptilian stare. They just don't blink very much. Some of them have some postural abnormalities with the neck pulled backwards. Pseudobulbar affect is inappropriate laughing or crying. Then they have dysarthria, which are speech changes, difficulty swallowing, and then they have some frontal dementia. So you think of Alzheimer's disease, you think of memory problems, right? They have trouble remembering. This is a little different. The memory is not the biggest issue. It's more of an issue with what we call executive function. So that's higher planning, organizing, than executing. Difficulty planning a meal. Difficulty paying the bills, because it takes a lot of thought and organization. That's where they start to break down. And then some behavioral changes. Common ones include apathy. That's often confused with depression because they become a little more apathetic. Disinhibition sometimes, some social inappropriate behavior. And some dysphoria, which is sadness, and some depression. So this was the criteria for 25, 30 years. This is what we had. This was our toolbox. And the NINDS is the National Institutes of Health, the Society for PSP. And you'll notice all these criteria I'm going to give you today, there's going to be broken down into possible, probable, and definite. Definite always requires a pathologist. So in these diseases, that means autopsy. So we can't give a patient a definite diagnosis. We can only give them possible or at best probable. So you'll hear that a lot when you go to doctors. You probably have PSP. But they won't say definitely, and that's why. So these criteria existed for a long time. You need to be a person greater than older. It has to get worse. This is for possible. You've either got difficulty with moving the eyes, or you can move the eyes, but they're slow when you move. The velocity of moving the eyes is very slow, and you have early falls. Then there are several other diseases that can mask these symptoms, and you have to rule those out, and I won't get into those now. Probable would be same as the above, but you have both the vertical gaze palsy and the early falls. I want to take a little break to talk about a little epidemiology because this is important for you to understand, again, the difficulty making the diagnosis. When we have criteria, all criteria have things called sensitivity and specificity. Specificity is the ability of a test or a criteria to correctly identify those that don't have the disease. In our case, this criteria is very specific. 95% is fantastic. You don't get that high very often. So that means if you fulfill this criteria, we're pretty sure, 95% sure, you don't have something else. You probably have it because you fulfilled the criteria. Very specific. Sensitivity, however, is the ability of a test to correctly identify those with the disease. And this criteria is abysmal. At the first visit, it is only 24% sensitive. It misses, what, 76% of the people. So in other words, if you don't fulfill this criteria, you still may have it. I want to go through this a little bit more diagrammatically to show you what I mean. Let's take, there's a group of people with the disease. That's what that represents. And then you got people over here that look just like them, but they've got something else. And you've got people over here, and they just look like them, but they've got something else. And you design a diagnostic criteria that's very broad, okay? Very broad. And you'll find that this diagnostic criteria covers everybody with the disease. That means that that diagnostic criteria is 100% sensitive. It gets everybody. But look what else it does. It picks up these people. It picks up these people. If you use this criteria, you're going to be telling a patient they have a disease, and they don't. So you want to narrow your diagnostic criteria. So you make it narrow. And this way, you're highly specific. Everybody that you tell has the disease does have the disease. But look what happens. You miss people over here. You miss people over here. And sensitivity and specificity are like the yin and yang. Once you tighten one up, you loosen the other. What you want is perfect criteria. You want something 100% sensitive and 100% specific. But good luck with that. In medicine, that doesn't happen. So that criteria that we used for many years was this specific one. It was very specific, but it missed a lot of people. And we knew that, because we could tell. Sometimes you don't fit the criteria, but you're looking at the patient and you know what they have, but you're stuck because they don't fit the criteria. Let's go back to Mr. T. Mr. T finally gets to see a neurologist again. Mr. T is found to have a masked face. His speech disorder is kind of strangled. His slowness is symmetric on both sides. He's got rigidity more in the neck than in the arms and legs. You do a pull test, that thing where the doctor pulls you back. He stumbles, falls into the doctor's hands. And his eye movements are full, but they're slowed. Okay? So let's go to our criteria, and we'll see how Mr. T does. All right, gradually progressive. Yep, it was progressive, so he fills that. Age greater than 40, Started in his 60s, I think. Vertical supranuclear palsy, no. He doesn't have it. He can get his eyes to the full range. Slowed saccades, yes, they are slow. Falls within 1 year, no. Excuse me. He didn't fall, I'm sure you don't remember, but the slides were, he didn't fall until about 2.5, 3 years. So Mr. T does not fulfill the criteria for PSP that we used for 25 years. And for 25 years, this is what we looked like to our patients. And this is what you looked like to us. And this is how all of us were feeling. Because we knew that Mr. T had PSP, but we couldn't tell him that honestly. We could say, well, I think you do, but I'm not sure because you don't fulfill the criteria. So last summer, this came out, and they did this study differently, and they've created new criteria. How this study went is they went to brain banks. People that had died donated their brain from autopsy to science. We looked at the brains. These are 9 brain banks across the world. Everybody got together, and then they had the diagnosis. These people have PSP, definitely, because we had their brain. And let's look backwards. What did they look like in their life? And then let's figure out how to make diagnostic criteria that direction. And what they found is PSP presents with some combination of 4 clinical features. Okay, so they have some kind of eye movement abnormality. They have falls. They can have lack of movement or very slow movement. And they can have some cognitive problems, some combination of those. Then what they did is they took these 4 cardinal features, and each one, I'm not going to go through this in detail, but each one has a hierarchy. So I'll give you the example of eye movement abnormalities. If they actually can't move their eyes, that's the highest criteria. If they can move their eyes but it's slowed, that would be the middle criteria. And I won't go through those, but if they have some difficulty with fixation of their eye, that's the lowest. So each of these 4 cardinal features have different levels. okay? Furthermore, there are some supportive features. These are clues that we use clinically. They don't respond to Cinemet. That's a clue. They have a different type of speech disorder. When we listen to someone's speech, patients with Parkinson's disease sound a certain way. Patients with PSP sound a little different. And I think you're going to get a lecture about speech later today. Trouble swallowing, light bothering their eyes. These are all clues. And then we use our help from radiology. We can get MRI scans, we can get PET scans, and they give us some clues as well. And then you get, this is the new diagnostic criteria. Extremely complicated. Look at this. You can have O1 or O2 plus P1 or P2, or O1 or O2 plus A2 or A3, or O1 or O2 plus C1, or A2 or O3 and O3 or P1, P2, CP. This is a diagnostic criteria formed by committee. That's what I call it. And we all know about committees. After weeks of meetings, this is what the committee finally agreed on. But then someone realized it was a watermelon. So we're back to square one. To be fair, though, why are these criteria so complicated? I can't remember that. I'll refer to it, but I can't remember that. No one can. But this is why these criteria are so complicated. It's because this was a brain bank, and what we realized is the disease of PSP looks so different in so many different people. So it's just the reality of how the disease is complicated. This top one is called PSP Richardson syndrome. That's named after one of the first authors back in the 60s that Alex mentioned. That's the classic early falls eye movement abnormalities. That's the classic form. But we also recognize that some people present with gait freezing, and I've seen them for years. They come to me and they just freeze very early, and they don't have anything else on their exam to support anything. Their eye movements are fine. Who were they? For years we didn't really know, and then we started getting autopsies, realizing these people had PSP. Some people look like Parkinson's disease in the beginning, and you give them levodopa, and they get better, and you're sure they have Parkinson's disease, but then as the years progress, something starts looking a little fishy. Some people present with those behavioral abnormalities and cognitive difficulties, and maybe don't have motor symptoms. Some people just have the eye movement abnormalities. Some people have a certain speech and language problem. Other people have corticobasal syndrome, and which we'll get into, and falls. So when you look at this diagnostic criteria, you can now see why it's so complicated. The reason we have so many different areas of where you can pick something is you've got the probable, you've got the possible, and the different types. So let's go back to Mr. T. What does Mr. T have? Well, his ocular motor dysfunction, he had slow saccades, so that's called O2. He fell within 3 years, so that's P1. O2, P1, I can now tell Mr. T that I think he has probably PSP. A few things on imaging. I'm not going to concentrate on imaging because you're going to get a talk later, but we see wasting of the midbrain, atrophy of the midbrain. Here's a midbrain with PSP. Here's Parkinson's disease. I think you can appreciate it smaller. The best way to look at it is a profile. And here's the midbrain here. And it's called the hummingbird side because it kind of looks like a hummingbird. You've got the small head of the hummingbird and the beak. Here's comparing. Here's the hummingbird sign with PSP. And this is what a normal midbrain, or at least a patient with Parkinson's disease, look like. One last thing about these diagnostic criteria. You'll notice some of them have eye movement abnormalities and cognitive. They might not have Parkinsonism. So this slide I kind of changed. Most people with PSP have Parkinsonism, but some of them are outside the circle of Parkinsonism, and they present with other symptoms. Let's go to Mrs. P. Mrs. P is a 74-year-old right-handed woman. She's a farmer. She's a mother of 4 children. Thanksgiving, she was trying to whip some cream, and she noticed she had trouble doing it. Then by March, her forearm was cramping, so she was given some muscle relaxants. Didn't really get better. By October, her arm was hurting more, her gait was slowing down. Next Thanksgiving, not only was it really difficult to whisk the cream, but she was noticing when she was cooking that she would get these jerks. By the summer, her granddaughter got married, and her family really noted she had slowed down, and her right arm was fixed. A neurologist finally saw her. She had rigidity, mostly on the right side. She had severe slowing on the right side. Her arm was in this fixed, crampy position, and she had what's called apraxia. Apraxia is when you have the strength to do something, you have the sensation to do something, but you can't do it. And it's usually a goal-oriented, like, show me how to brush your hair. And even though you're strong enough to do it and you have the feedback, they can't figure out that complex movement. So she had Parkinsonism, she had slowness, she had rigidity. And we all know that there's another disease that causes Parkinsonism, corticobasal syndrome. Corticobasal syndrome is a combination of many symptoms. It's usually highly asymmetric. Parkinson's disease is asymmetric, but this is really asymmetric. And then people have rigidity, the apraxia. Myoclonus is jerks, quick jerks. Dystonia is a fixed limb. An alien limb is a phenomenon where the arm might move and do something semi-purposeful, like that, out of the control of the patient. A little bit of nomenclature difficulty. You might get confused. Why do some people call it clinical corticobasal syndrome and some people call it corticobasal degeneration? What's the difference? Well, the syndrome is a clinical diagnosis, meaning we just talk about them with their symptoms and signs. Degeneration is a pathologic diagnosis. It needs the pathologist. We would hope that this would be the same thing. However, look how bad this is. First of all, let's go clinical to pathological. These are older cases, but there were 36 cases. They had CBS in life, but only 20 on autopsy actually had the disease. Only 56% were right. So what did they have? They had PSP, they had Alzheimer's, Creutzfeldt-Jakob, other dementias, and they looked like they had corticobasal. The other direction is just as bad. Let's go to a brain bank. We'll take 29 cases with the disease, and then we'll look backwards. What were they like in life? What were they called? And only 12 have been given the diagnosis of corticobasal syndrome. Only 41%. Other people had been called in life, PSP, Alzheimer's, etc. So new criteria came out in 2013. They bundled rigidity, dystonia, jerks, some apraxia. I won't get into some of this, but they bundled these syndromes, and we have this new criteria. Okay? So probable means it's asymmetric, and you've got 2 of these and 2 of these. Possible, it's similar, but it could be symmetric, and you only need 1 of these or 1 of these. So let's go back to Mrs. P. She's asymmetric? Yes. She has limb rigidity? Yep. She have dystonia? Uh-huh. She have myoclonus? Yeah, she had those jerks on Thanksgiving. Does she have apraxia? I don't think I gave you... Yes, she did have apraxia, actually. Right. Did she have a cortical sensory deficit? Well, actually, she didn't. Did she have an alien limb? No. But I could say to her, you have possible PSP. You have 1 of these. So at least you fulfill the criteria for possible. Here's an MRI. Again, I'm not going to concentrate on this, but you'll notice a normal brain and a highly atrophied or wasted brain asymmetric from one side to the other. Let's go back. Remember I said only 12 of 29 cases on autopsy have been correctly diagnosed. And what were some of those other diagnoses? Alzheimer's disease, other dementia. Corticobasal syndrome sometimes presents with a dementia, not Parkinsonism. So they have different types. They have a frontobehavioral spatial syndrome, which is presenting with cognitive difficulties. There is a type that has a speech problem, a very difficult speech. They're really groping for words. Their grammar is very poor, and that's how they present. And some look very similar to PSP. So corticobasal syndrome has different subtypes. The classic, those asymmetric types, but also some cognitive types, some speech and language types, and some that look just like PSP. So similar, I'm going to change my circle and put CBS on the outside here with some have Parkinsonism, but some don't. Last case, and I'm almost done here, Dr. G. Dr. G is a 57-year-old female psychologist. When she was 51, she developed bladder issues with occasional incontinence. She went to a doctor, and they just called it neurogenic bladder, which is very generic. It's not structural, must be neurologic. But that's it. By 2015, she had problems with her facial expression. Her handwriting was small. She had a slow, shuffling gait. Went to a neurologist. She said that, well, I've fallen twice. Her bed partner states that when she sleeps and she dreams, she acts out her dreams. She kicks, she punches. She has some bradykinesia. She has some rigidity. Neurologist says, you have Parkinson's disease. So he gives her Sinemet, and she does get modestly better, but progresses. And by 2017, she's falling. When she stands up, she gets very lightheaded, like she might faint. By late 2017, she's really falling twice a month. By January, she actually fainted when she stood up. And the neurologist finally figures out by March, you don't have Parkinson's disease, you have MSA. So once again, you've got Parkinsonism, and then you've got a third disease that has Parkinsonism, but is not Parkinson's disease. MSA is classically Parkinsonism that doesn't respond or only modestly responds to levodopa, and you've got autonomic features. The autonomic nervous system is the part of our nervous system that controls our blood pressure, our bowel and bladder, our sexual function, and our sweating. So you've got problems with inability to control your blood pressure when you stand up. That's called orthostatic hypotension. Men have some erectile dysfunction. People don't sweat. They get constipated. And then there's a slew of bladder issues with incontinence, sometimes retention. They can't empty their bladder. Furthermore, there's different types. You've got the type that I just described, and then some people don't have Parkinsonism at all. They have what's called cerebellar type, which is, I can't get into, but there's different features. They don't have Parkinsonism. So we call it MSAP and MSAC, but they both have this autonomic function. So once again, Parkinsonism, MSA. Interestingly, in North Americans and in Europe, people more have MSAP. In Japan, more have MSAC. We don't know why. I want to have one slide on this acting out of dreams. When we dream, most of our dreaming is during REM sleep. In REM sleep, the normal is that we're paralyzed. We can breathe, but we can't move. That's why we don't respond to our dreams. But in patients with this disorder, they lose that paralysis. So if they're being attacked by something, they fight back. This is more than just vocalization. This is actual kicking, punching, that kind of thing. And we always ask that. And why? Because it's a pretty good differentiation here. People with Parkinson's disease and MSA tend to have it. PSP and CBD tend not to have it. It's not 100%, nothing's 100%, but it's pretty good. So MSA has criteria. You've got probable, sporadic, you've got autonomic function, and you've got either levodopa unresponsive Parkinsonism or cerebellar ataxia. And then there's possible, and I won't go into this for the sake of time. So let's go back to Dr. G. Was she sporadic, meaning no genetic? Yes. Was she progressive? Yes. She had some urinary incontinence. I didn't give you this information, but when we stood her up, the top number fell at least by 30, or the bottom number fell at least by 15. So we have criteria for what that means. And she did fall like that. She did have poorly responsive Parkinsonism. She did not have cerebellar ataxia. So we can tell Dr. G that she has probable MSAP. A few slides, you're going to get a lecture on radiology, but oftentimes we see this dark area here in the putamen with a little light area at the lateral aspect. We see some wasting of the pons. The British called this thing. You see this plus sign in here? The British have these hot cross buns. And so this is the hot cross bun sign. We also do autonomic testing. This is what we do at Mayo. It's a sweat test. This is what a person should be like. This is what a person with MSA, they just don't sweat. So in summary here, this is what I really want to have you remember what this looks like. These are rough estimates, just in comparison. Parkinson's disease, about 840,000 people. PSP, about 20. MSA, about 15. CBS, about 2,500. So in conclusion, how do we make a diagnosis? I always tell my patients, making a diagnosis in this field is like being on a jury. You never really know whether the person committed the crime. You don't know with 100% certainty. You collect evidence, you weigh the evidence, you make a decision, the best decision you can make. Most, but not all patients have Parkinsonism. It's frequently confused with Parkinson's in the beginning, but they have a lot of overlapping features. And we're getting better with clinical diagnostic accuracy, but it's not perfect. All right, thank you very much. Yes, I guess I have time for one or two, but not very many. Any questions?
If this involves a misfolded protein, why
Right.
isn't it called a prion disease?
Well, that's a great question. A prion disease was classically described in like the mad cow disease or the Creutzfeldt-Jakob disease, right? Where there's a misfolded protein and then it goes to the normal protein and causes that normal protein to misfold. Now you've got two of them, and then they go to normal proteins and cause those to fold. Now you've got four of them, et cetera, et cetera, et cetera. And that prion, the groups of prion diseases have been well recognized, and they're there. The new hypothesis over the last 4 years is this prion hypothesis, where these diseases do, this is a hypothesis, do spread by a misfolded protein taking a normal protein and misfolding it. So we call it a prion hypothesis. But there's a lot of debate because the prion diseases are infectious. So you take a patient with Creutzfeldt-Jakob, and if there's surgical instruments that you used on them and you use those surgical instruments on somebody else, you can infect that patient. And yet we're not seeing any of that in these diseases. So people are debating, do we call them prion or do we not call them prion? It's a similar process, but there are certainly unique things that we see in the classic prion diseases that we're not seeing in this.
My sister was diagnosed with PSP and possible MSA thrown in. So what you're saying is that just not an exact diagnosis because it's hard to tell, or do
Yeah.
they?
So there's so many overlapping features. I don't know your sister, but I suspect she's probably got some bladder issues. A lot of patients with PSP have bladder issues. We usually think of bladder as MSA, but PSP patients get it as well. And so sometimes they overlap, they don't present like the textbook says they're supposed to, and we struggle. Sometimes I might say you have Parkinsonism, but I'm not sure what type yet. And then you follow them for a few years and eventually you usually make a decision. But there are different labs that we can use, and we think we're getting better at trying to tell people earlier and earlier what they have. But especially in the beginning, it's difficult. I also want to emphasize, sometimes if you haven't fulfilled the criteria yet, that's interestingly good news. It doesn't sound like good news, but you can see we have criteria. You have to be bad enough to fulfill the criteria. And if you're presenting and you're not bad enough yet, in a way, you're frustrated because you don't have an answer, but in a way, you haven't progressed enough for us to make a diagnosis yet. So it's a mixed bag. Okay. All right, thanks.